Good morning and welcome everybody to my session, this session on cardiomyopathy. Now the problems with the cardiomyopathy, intraoperative, when it is hypertrophic cardiomyopathy is typically these patients are on beta-adrenergic antagonists or amiodarone and may even have an implanted defibrillator. One must ensure that the patient has had all scheduled medications. The defibrillator must be turned off if interference from surgical devices like unipolar electrocautery is expected, and external defibrillating equipment must be at hand. The main goal to help prevent obstructive physiology are maintain the preload and afterload, maintain a relatively slow sinus rhythm, and recognize the undiagnosed obstruction. Afterload and preload are maintained with heart rate control and maintenance of systemic vascular resistance during induction, maintenance and emergence from anesthesia. Junctional rhythms are not tolerated well due to the dependence of the left ventricular end diastolic volume on atrial kick. Early detection and treatment of a junctional rhythm is imperative. Sudden hypotension and dynamic systolic murmur should raise the suspicion of undiagnosed left ventricular outflow tract obstruction. In these cases, drugs that increase the heart rate or contractility should be avoided. Emphasis should be on filling the ventricles and slowing the heart rate. This can be accomplished with the fluid boluses, phenylephrine and beta blockade. Restrictive cardiomyopathy. Initially, try to determine the levels of venous congestion by looking for jugular venous distension, hepatojugular reflex, or peripheral edema. In patients with evidence of congestion, diuretics are the preferred treatment. One must also be wary of arrhythmias. Anti-arrhythmogenic treatment with beta blockers or amiodarone is the mainstay. Preoperative echocardiographic studies are essential to define the level of diastolic dysfunction. Restrictive heart are rate dependent for cardiac output. Thus, rate control and maintenance of sinus rhythm are the keys to a safe anesthetic. Now come to the dilated cardiomyopathy, that is DCM. Hemodynamic goals of maintaining preload and sinus rhythm should be accomplished by avoiding myocardial depression and preventing large increases in the afterload. Careful induction using a technique that preserves the myocardial contractility, preload, and rhythm. Moderately elevated heart rates are better tolerated since they prevent large increases in the end diastolic volume. Therefore, drugs like ephedrine, epinephrine, and dopamine become the treatments of choice for the hypotension. Arrhythmogenic right ventricular cardiomyopathy, that is ARVD. The main goal in the patients with ARVD is to promote forward flow out of the right side of the heart. This depends on balancing adequate preload with the myocardium's ability to contract. A pulmonary artery catheter or transesophageal echocardiography is indicated in intermediate to high risk procedures. However, one must be ready to handle any potential malignant arrhythmia associated with the pulmonary arterial catheter placement or anesthesia administration. Familiarity with the AICDs and anti-arrhythmia medications is essential. Afterload reduction by maintaining the low pulmonary vascular resistance and left ventricular function are also imperative. The emphasis must be on maintaining the normocapnia, preventing the hypoxia or acidosis to minimize the changes in the pulmonary vascular resistance. Post-operative care depends on the operation. For minor procedures, it may be adequate to monitor in a telemetry or step-down unit. For moderate to high-risk surgery, intensive care settings are the safest. Restarting the patient's preoperative medications in a timely fashion is critical. For patients with AICDs that were turned off, trained personnel must be available to reprogram the device after surgery. If not, one must keep a defibrillator at hand and monitor the patient closely for malignant arrhythmias. Afterload reduction by maintaining the low pulmonary vascular resistance and left ventricular function are also imperative. The emphasis must be on maintaining the normocapnia, preventing hypoxia or acidosis to minimize the changes in the pulmonary vascular resistance. Post-operative care depends on the operation. For minor procedures, it may be adequate to monitor in a telemetry or step-down unit. For moderate to high-risk surgery, intensive care settings are the safest. Restarting the patient's operative medications, pre-operative medications, in a timely fashion is very critical. For patients with AICDs that were turned off, trained personnel must be available to reprogram the device after surgery. If none is found, one must keep a defibrillator at hand and monitor the patient closely for malignant arrhythmias. Follow-up. Cardiologists should be alerted to, if not involved with, these patients prior to the operative day and informed of any perioperative events. The patient should be evaluated to ensure that their medications have been restarted and that their AICD is functional. If any clinical sign of decompensation are evident, an evaluation of cardiac function involving an echocardiogram must be pursued, with any changes worked up as potential myocardial infarction or a need to further optimize the medications. Now we come to the end of my lecture with the summary for cardiomyopathies. Epidemiology, prevalence varies with classification. Most adult patients arrive with the diagnosis in hand prior to surgery. HCM and DCM are the most common. Perioperative considerations. It will be preoperative considerations. Input from cardiologists is imperative during a very thorough preoperative workup of these patients. Once the type of cardiomyopathy is determined, one must plan an anesthetic that preserves the compensatory mechanism in place to overcome the pathology. This entails a complete understanding of the medications and monitors. Intraoperative considerations. HCM, dynamic outflow tract obstruction, is major concern. Maintain the preload, afterload, relatively slow sinus rhythm, avoid tachycardia. DCM, avoid myocardial depression and large increases in the afterload. Monitoring. Low risk procedures may be safely performed with standard monitors. For intermediate and high risk patients, invasive arterial monitoring should be employed. Central venous monitoring or transesophageal echocardiography. Thank you.